Welcome to the Wednesday, November 19th, to our DDRS Advisory Council meeting. This is being recorded. Can you guys hear me okay?
Yeah, just you don't have to.
It just, no one cares, basically. No.
We love you,
I'm kidding.
Jessica.
Well, it's hard to hear. You can't tell if you're hearing, so. Okay. I know. Okay. So we will go ahead and get started. We got a pretty full agenda today. Once again, having issues with the video, so we might have to put that off to the end, but that's okay. We'll figure that out. If you need an agenda, we have an agenda up here as well. So just come and let me know. Okay. All people are empowered to live, love, work, learn, play, and pursue their dreams. And we'll get into this a little bit more as we talk through our mission and our vision at DDRS. And I will get rid of that in a second as well when my tech guy comes back. So, okay. And just want to share our logo, as you guys have hopefully seen this on our website as well as in some of our materials. The DDARS new logo, which includes and obviously we've lucky enough to have the Bureau of Better Aging join us within our DDARS family. So just wanted to make sure you guys have seen this and it's on our website, and just sharing out again. And we will skip this video, which Kelly and Kathy are very glad about because their faces will be on the screen talking. And so they'll be excited if I can't get it to work. No, I'm just kidding. Thank you. Thanks.
See, we don't need to watch it now.
So we'll work on that during the break to get I haven't been able to get the volume to work. So we'll work on that and share that at the end. So again, we have a pretty big agenda here, as you guys have seen. Kelly Mitchell is going to present right services for the right people at the right time. And then we will have, Holly is unable to join us today, unfortunately, but Kathy and Kelly will fill in for her as best they can and just go through waiver sustainability strategies, case management before update. I will discuss the training registry and give you guys some update on some exciting numbers as we're seeing thousands of people who have taken the training and registered. And then the beads, if there's any questions about the beads and BRS data that was sent, that we, as you guys know, send around quarterly via the Indiana statute. So Teresa Colazar is here as well in case you have any questions about that. And then we have the parking lot at the end. So if you guys have anything that we don't get to, hold tight and we will make sure to address that at the end. Sorry, I talk very fast, as you know, so. Okay. I'll turn it over to Kelly.
Jessica, do we need to do a roll call and introductions?
We do. And I do not have my list in front of me, but I can try to remember. Thank you. I appreciate it. I'm just going to go around the room, and then the people who are not here, I do know. Let's see. Carrie is here.
Yeah.
You just want to go around and say your names. Go ahead. That's probably faster than me.
Carrie Lee, Indiana Family to Family.
Kim Han, Parent Advocate.
Ann Titus, Benchmark Human Services.
Kate Barrow, Indiana Governor's Council for People with Disabilities.
Tom Sean, the Arc of Indiana.
Kathy Robinson, Associate Director for DDARS.
Kelly Mitchell, Director for DDARS.
Good morning, Teresa Colazar, DRS Director.
Jessica Harlan York, Chief Operating Officer of DDRS.
Heather Dane, Chief Program Officer with BEADS.
Katie Stafford Cunningham with NRF.
Melissa Keys with Indiana Disability Rights.
Jim Wiltz with NABC.
Laura Fife with Connections Case Management.
Tilly Clark, Self Advocates.
Great. And I think we have absent today, Sean, Lisa, Lexi, and Loretta, I believe I've got everyone. So unfortunately, we're not able to join us today. Okay. Thanks for the reminder.
All right. Well, good morning, everyone. Again, I'm Kelly Mitchell. I'm the Director for the Division of Disability, Aging, and Rehabilitative Services. I wanted to speak a little bit today about a phrase you may have heard me utter during our last quarterly financial review. And you see that on the screen in front of you, right? The right services for the right people at the right time. This is a guiding principle that we have utilized internally for the last, 18, 24 months at a minimum. As we look at how do we support Hoosiers with disabilities and as they age in the most appropriate manner. And the statement itself, I hope, is taken in the intent in which it's meant. So I want to break that down just a bit, and we'll lean into this more as we move into the Bureau of Disability Services presentation. They're kind of companion pieces, if you will. But we talk about, I'll go to the middle, the right people. I think many of you have heard us converse over the last year or two about our eligibility determination processes or level of care assessments, if you will. There have been modifications across the waivers for health and wellness, the pathways for aging waiver, and we will soon be implementing some changes for the waivers that have historically supported individuals with intellectual and developmental disabilities, which would be the CIH, or the Community Integration Habilitation Waiver, and the Family Support Waiver, as well as IDD supports through supervised group living, again, eligibility, if you will, for those traditional Bureau of Disability Services targeted for individuals with intellectual and developmental disabilities. The intent is not to find ways to deny individuals services, but to ensure that at that time, so the right time, at that time, not only does the person have an intellectual or developmental disability, but they are also functionally eligible. So let me give an example. A child may be born with a developmental disability, let's say Down syndrome. And thankfully, that child has no complicated health-related needs that would cause any additional support needs for activities of daily living. Beyond that, what would be typical for a 6-month-old, a 12-month-old, an 18-month-old. So at that stage in their life, perhaps there is not the functional need for a waiver support. That child and family may and likely will access services through first steps if there are some delays in development, and utilize those to move toward those goals that are family-centered. There would be service coordination provided, and through that service coordination, build some skills for the family and some connections in the community. If there are needs that continue to exist at the age of 3, Department of Education also continues to offer some supports. If the family would have private insurance, or if they are Medicaid eligible, there would be services and supports available through that insurance support. If Medicaid eligibility exists, there could be services through some state plan, the EPS-DT services, some diagnostic and periodic screening, therapeutic services available there. So let's talk about the right services. So let's take that same child, and as the child gets older and moves into high school, still doing well with family supports, has relatively independent skills in the home and not a lot of need there, but now planning to transition from high school and looking at those options. And perhaps we're looking at employment. There might be a referral to Office of Vocational Rehabilitation. And as we move toward that, perhaps there's an assessment at that time, and the individual now does have some needs. Perhaps there are some deficits in activities of daily living and functional need, and there might be some waiver services and supports. The person qualifies, and those services and supports are appropriate to the need. So perhaps this individual needs to gain some skills in home management and community access. Perhaps those are time limited. Some individuals may receive services 1, 2, 3, 4, 5 years, may gain those skills, develop relationships, natural and typical supports and no longer need those waiver services. Others may need those services for an extended period of time, particularly those that perhaps have more complex needs and limitations. So that would be the right services appropriate to the right time. And we'll speak more to this in our presentation around the Bureau of Disability Services. But really looking at this person-centered, needs-based, it's not waiver and other supports are the entire answer, really thinking about what are the goals and the outcomes that we all desire. So as we design a system, a model of support, we want to ensure that from the start and throughout, that we are ensuring that we have identified the appropriate services at that season of life for that individual. So that would be the right time. And that the need exists, the functional eligibility, that level of service need. So there's first eligibility and then there's level of service need. So that is what guides us as we are moving through our stages. That's good.
I would just add, I think, to what Kelly is saying for this slide. I know this has been more of a sentiment in particularly the last, as you mentioned earlier, that time frame, but it also is another way of saying and reframing that the core philosophical components of the life course framework, right? So what we put forth in that effort over many years now is that kind of family-driven grassroots perspective of not meeting people where they are and providing the supports where they need it. And I know some of you will recall that image. I couldn't find it before this meeting, where it shows the system kind of coming in where maybe there are gaps or holes in somebody's supports in their day-to-day life, that's where waiver and other services might come into play in terms of coming in to support that person for that particular need, and that right service at the right time kind of concept. So I wanted to just add that so that everyone's kind of connecting the dots, that this isn't a separate thing. They're all interconnected.
Yeah.
I have a
Yeah.
question. So like, say because I know that they're thinking about like changing the waiver and stuff, like you said. What if someone is excelling in some stuff, but they still need the support? Would you take that away from them or no? Like, would you give them a different part of the waiver?
I think I understand your question. If you're saying there's still an identified need, that's what we're speaking to. Waiver and frankly other supports, it could be supervised group living, should meet a need. And it's not, and by that, it's like there's an identified need and there's a gap in supports, whether through that individual's strengths and assets or family and community, other non-waiver or non-public resources that might be available. So no, they wouldn't be taken away merely because you may be doing well in another area. It's
right,
looking at the whole.
Okay.
But in that same, if I might, I'm going to kind of expand on that, and we'll speak to this more. And the reason we're bringing this forth today is actually to start having these conversations here at this advisory council as we move toward waiver reset.
Yeah.
But the other piece to that is, while there may still exist a need here and a lack of available support or personal strengths and assets, if the individual is doing well in another area, then a service through, let's just say, waiver shouldn't remain just because it always has been or it's available. So the service, the support, the level of service and support should meet the need. So perhaps the service and support doesn't disappear, but it diminishes,
Okay.
right?
Hmm.
And maybe in another area, the level of support was at one point here, and perhaps that need has grown
Mm.
because we all know our needs, our abilities change throughout life.
They
And that's
do.
dependent on a lot of things. It's our environment, it's our physical health, it's, family support, all of those things. So what we're trying to reflect is that there should be more fluidity in the services and support. And what we have historically seen, and we'll speak to that, is once individuals, I'll just say eligible, are eligible for, let's say, a waiver service, we very seldom see that ebb and flow. It's generally, there's just a continued growth and not really an assessment of where needs and how do we best address outcomes. So trying to improve upon that, if you will.
Okay, because I did the waiver reset meeting for self-advocates, and then I'm doing one tonight.
Oh,
So,
good.
they pretty much went over a lot of stuff,
Mhm.
and we were like, all of the self-advocates were communicating, like, some of them were communicating about transportation, and we should add CIH and add another one with it, with the CIH as residential and CIH waiver, because some people need their services still, but they're not getting the services that they need.
And we're going to speak to this a little bit later. Kathy and I both will. I'm actually glad that you stated that right now. I think one of the challenges and the opportunities that we have with this waiver reset is to move away from, and what we hope is, we don't want to look at this as what services do you want on the waiver.
Right.
We don't want to look at this is what exists, so what can we add to it and be constrained by the current model. It has all been with the best of intention, but what has happened over the last several decades is we've kind of just tweaked waiver and we've added and layered and not really looked at it holistically. So what we're trying to do is, when we say reset, is what is it we want as outcomes for individuals? And it's not about what services, but what model gets us there, how do we improve upon, and really wanting to hear, about those things. And that's a bit challenging because we know what we know, right? We know the names of the waivers that we have now, and we know the services, and you're going to hear me lean into this. But as we talk about service coordination, case management, or care management, or whatever words we want to use, the process should never be, I'll speak to Kathy. Hi, Kathy. You've been, we've talked about you have some needs here, and you've been identified as eligible for waiver, and you've been approved. You've been approved for family support waiver. What services do you want?
All of them.
Yeah.
So oftentimes, I'm being very raw and honest, that's what's happening. Frankly, the name of the service doesn't matter. That's just a way that on the backside, we tie it to the appropriate definition and funding code, and making sure an individual and a family shouldn't have to be worried about the name of the service. And sometimes that's overwhelming. I don't know. I guess I want it all, right? That would be your response. So really starting back, and you heard me speak the first steps. I think First Steps system does this very well. I might be a little biased because I've been around a long time. And when First Steps launched back in the 90s, I was one of those first service coordinators with individualized family service planning. And we would spend a lot of time, I call it kitchen table conversations, talking about, tell me about your child, Tell me about your family. What's important to you?
Mhm.
What are your goals? There would be short-term and long-term. Then we talk about how we got there. And some of that was services that we might be able to provide, but it was also connecting people to other resources, providing some consultation and support and connectivity for future state. So when we say reset, I do want everyone to hear loudly. We're not trying to take away any waivers. The
Okay.
names aren't going to exist anymore. We know that. They'll
Right.
be different.
They
It's
will.
going to look different.
Okay.
We're challenging this advisory council. We are challenging, we're out now, we're going to mention this, engaging with stakeholders. Let's not be constrained by the service array now, because quite frankly, we have like an overly burdensome array of services. It's confusing.
Hmm.
Let's talk about how we can do it better to get to where I know we all want to go. Jim, I see your head nodding, you know.
Because, sorry. Go. My mom has worked with First Steps because she's an occupational therapist, and she still works with First Steps, and she works in a school. So I understand like a lot of things, and yeah, she's always been supportive. So thank you.
I think everybody kind of understands the point of the right services, right people, right time. And that makes sense when redesigning a service, right? I think that where there's anxiety is that you're replacing stuff that we kind of know. I mean, nobody really knows.
Absolutely.
I mean, the OBA, whatever, we don't exactly know what goes into the black box to come up with the algo. But we have a pretty good idea, right? We got the ICAP and those kinds of things. And you're saying that we need to, not only there's going to be the eligibility, but then there's also the
Service
what
plan.
services are, you know, relevant for you. And the new level of care assessment tool that you all have purchased and bought into has the potential to do both, but
Hey,
not
Jim,
knowing
can
what
you
that
speak? I don't think anyone ever tells you this, but can you? Yeah.
Nobody
You're not loud enough, Jim.
Nobody ever tells me to talk louder.
She just said you have to. She couldn't hear
That's
you.
never
I
happened.
know it's never happened. Mark it down, but because it doesn't pick it up yet.
Okay. All right. I'll try to be more mindful of the microphone. No, I mean, but doing away with the OBA and the algo, which my understanding is that that's kind of moving away from that.
Yes.
What that is replaced with obviously has real ramifications, you know? And so I think that, and I'm not criticizing, I'm just saying that by saying, oh, we're not doing this thing that everybody's all familiar with, and we're going to replace it with this sort of nebulous thing that we haven't decided yet. I mean, that's kind of for somebody like you and for providers, you know, for everybody in the system, it's like, okay, I mean, we can get behind this concept, but at the same time, it's like the devil's in the details, and we don't really have any idea what the details are going to look like, you know? So that's where
I mean, I think
And
I
we'll
would
be sharing.
Yeah, I think we'll have some opportunities. I think part of the reason we're doing the stakeholder engagement is that we don't have everything carved in stone November 19th of 2025. And so in some ways that we recognize that in talking through it, it creates some anxiety for folks because there's some unknowns. The benefit to talking about it is we get the opportunity to then hear from people what works for them, what doesn't work for them as far as their day-to-day life. And part of, I think, looking at what's currently happening in the service arena as far as what Kelly will be talking about in the, evaluation of what are people allocated, what do they actually need conversation is to help us inform what we ultimately look to from a systems perspective in that budgeting arena. Because if you have, you made a great point about something's working really well for me and I'm doing great because of this service, we obviously want to have a mechanism in place where we know that that's happening. I think what we see sometimes, however, is that the need appears to be a just in case. I need this just in case something happens. And that's not a functional assessed need. That's a fear or that's a preference. And CMS would say, per their federal regulation, that's not a functional assessed need. So we have to be able to hone in on where are we maybe needing to course correct in some of those spaces, because what folks need, we actually need to have visibility, clear visibility into as we head into a waiver reset scenario where we're really knowing where people's services and supports fall so that we know what needs to be preserved, what needs to be adjusted moving forward. So I know that I think we know that it's a difficult path when you maybe have some of the information and you feel like you don't have all of the information. We're in that right now and navigating it, but we also feel like this kind of transparent conversation, or at least sharing of where we think we need to head, is the opportunity to have that more direct conversation about whether or not we're on the right track or not. Melissa.
Thank you. So, and maybe you guys are going to talk about this later on. Can you talk about how choice or preference might blend into the difference between service need versus service want? Like an example, like transportation. If, I need transportation to get to my job, and one assessment or one determination is that, oh, you can use public transportation, but my preference is not public transportation. My preference is some other thing. Can you talk about how choice might still play into this? Or am I?
Go ahead.
Yeah, so it's actually, yes, I don't think it's always super black and white in
Right.
those situations. But I do think, for example, and I'll give this example because it is a real life one. I won't use any names except for my own. But, we have a lot of rural communities. I grew up in a rural community, not a lot of transportation options. And, a situation, let's say that somebody they're maybe learning a new skill, but one way that they can develop that skill is by going to the mall. I won't go into whether it's, interacting with people or whatever the area of need is. And they wanted to go to the mall every Saturday for hours, and wanted their transportation provided to get them to the mall every Saturday. Recognizing that that's a rural community and thinking about what does everybody else in that community who is not using Medicaid waiver services, what do they get, what is available to them, and what is considered normal to them. And in that scenario, in that community, it is not normal or typical for people to go to the mall 45 minutes away every Saturday for hours. I'm not saying that that isn't beneficial to that person, but when we look at kind of what is the waiver system responsible for, we're going to look at your community to say, what is typical for your community? Because the ultimate goal of the waiver is to integrate you, to have it look just like everybody else in your community. And so in that situation, we might help problem solve the transportation question about how could we make this work for you, and how could we help you if that's what you wanted to do. Whether or not we would fund all of those transportation trips and or supervision during that time is not necessarily something the waiver has to offer, because in your community, that is not what is typical. Now that might look different depending on where you live and what's going on in Broad Ripple or, wherever. Like, that may look contextually very different, but that is the way in which those waiver systems of services and supports are built and inherently designed from a federal perspective. Now, in that scenario, it could be, here's my transportation option that I don't like that option. And we would continue to work to figure out, why don't you like that option? Is that something we can overcome with you, or is it not? Is there another functional need there that we need to address in order to help you? Or is it just a personal preference? If it's a personal preference, we can kind of help try to mitigate that or meet in the middle somehow, or help them find another transportation option that is a preference of theirs. So a lot of those kind of happen at that team level discussion, and whether or not, and in saying that, if that is what we do for Melissa, does that mean that's what we have to do for Katie? And that's not necessarily the case either. And that's where the person-centered aspects of this come into play, that we might do something entirely different for Katie, because Katie doesn't mind public transportation, but she needs support initially to figure it out, and then she's going to do it by herself, right? So that's the other part of, I think, the person-centered aspects that we may talk a little bit more about as well, that people also maybe are confounding with choice and preference and functional need.
Gotcha. Thank you.
Quick question. So I think, and again, recognizing this is far off and still a lot of planning to happen, I think the eligibility aspect is relatively objective, depending on the assessment tool that's utilized. I think what you're talking about here on kind of the needs-based, particular for an individual based on where they are, et cetera, can be very subjective. Mm-hmm. So who do you envision would be the ultimate decider of those decisions? And I guess you mentioned kind of the teams. Is the teams making those decisions? Is someone at BEADS ultimately saying yay or nay on these services? I think it's such a subjective determination for those individual.
I think it's layered.
Yeah.
And Jim, you referenced this, and I hope I was clear too when I spoke. The tool that we're launching soon, the new level of care assessment tool, is not only to be utilized for, or the goal is not to just utilize it for that initial assessment or eligibility determination, but also for service planning. So kind of identifying those functional areas of need, and whatever, approving, a particular level of service for particular categories. Now, to your point, there is some subjectivity, if you will, because it's person-centered. That would be the role of, the case manager to facilitate that process and discussion. And then we'll be leaning into, the case management, as we have been, really kind of improving the understanding, and quality and support there to just have those very conversations. And Melissa, I really appreciated your question. I think sometimes we don't like to hear that or address it, but if I need transportation and it's available publicly and I just don't want to use it, that isn't the role of waiver to step in, or any other publicly funded source, but I'll use waiver. That's not really a need. The need for transportation, but the need for waiver to support it doesn't exist. There is an option. If there are no limitations, other factors, as Kathy noted. But, Tom, there will be, and we'll speak to this. I'm kind of getting ahead of it, but I want to address the question, and perhaps it will knock a little bit of time off, later in some of the future. I think there are pieces at the state level that we're really working toward as we talk about more of a kind of a 360 and care coordination and looking across the whole. So if there are things that appear to be contradictory, if you will, that would be reviewed at the state level. And we're going to talk about this because we're doing some things right now and looking at kind of drilling down into a select group of individuals and their plans and kind of see what's going on. But there are some things that we're identifying that will also lead us toward that goal of reset. So I'll give you an example. If you have an individual that's on, I'll use the community integration habilitation waiver, and they are receiving what we lovingly refer to as a daily rate for ResHab. And that's meant to be, this person is supported for the day, right? What we have noticed in drilling down is that we have a lot of folks that are getting a high level of support, because there's different levels of that, tiers, in a daily rate. And they may also be receiving services through Medicaid state plan for home health aid. That is a duplicative service. A home health aide does nothing different than what a direct support professional in ResHab can do. That as part of care coordinate. Does the need exist, or are we working to fill hours in a day? And it appears in some instances that our goal has been, let's find a staff person to be with this person every hour of every day. That was never the intent of waiver services. It is not the intent of life course and person-centeredness. It is certainly not the intent of a least restrictive environment and support system. So those are some of the things that we're looking at, what we want to hear about, you know, and as we're looking at cases. So that might be something we'd look at. Is this a need? What's really happening here? So we would push back. But also on the other end, elevating, perhaps we've missed something here. An assessment doesn't always identify the all. That happens. I lovingly refer to those kitchen table conversations. Understanding the individual, understanding the environment, understanding the community, right? And the support that exists. The same person may have different needs dependent upon the environment and the community. So that all has to be taken into consideration. Okay.
Thank you. I'm trying to wrap my head around all of what we're discussing while also thinking ahead of where we might end up running into barriers. And the first thing I think of, especially when you're talking about examples of folks who live in rural areas, is the community capacity to support individuals with natural support. So where they may not have functional eligibility for a waiver service, but they may need a community support. How are we identifying, or what is the plan to identify what the community support need is? And are we, or are you all able to identify the capacity of the community to provide that support? If the capacity is not there, who are we working with to identify how to build that capacity up?
I think, you know, Kate, you know, you and I have had this conversation in other arenas. And I'm going to lean into, we just had an aging conference and Dr. Burke did this amazing keynote. And I think, you know, Katie, I'm looking at you. We've had this conversation with you and NR and Tom. We've talked about it. You know, Kim Dotson and I have had these conversations. Part of this is we have communities that truly aren't designed for individuals with disabilities, nor individuals as they age. Our communities are designed for young families and, you know, working members. And as we have thankfully deinstitutionalized, I mean, Indiana led the way. What happened is we didn't develop the communities. So we deinstitutionalized, and yet we have communities that aren't, I'll just use the word equipped, or aren't culturally ready. So there's work to be done in this, and the state can have services and supports and policies, but this really is, what we're talking about being innovative. It is more than just what services do we offer and what waivers are out there. A lot of what you hear me speak to is the advocate in me, Kate. When I drill down into some cases, what I see is we have at times built an institution in the community. That is not the intent and the desired outcome of home and community-based services. And in some instances, I will be quite frank, I see individuals who are more isolated in their community than they would be in an institution. That's not a good thing. That's not community. That's not home. And that when we're talking about waiver reset, that's the heart of this. Now, am I Pollyannish to think that we're going to be able to flip a switch and that happens tomorrow? I am not. But what I do know is it will not change if we continue to do this in the manner that we are now and just try to layer. Because to your point, I live in a rural community. A lot of folks may not know that. I am in southwestern Indiana, very small communities. I grew up in a very small town. Not a lot of resources and supports, not a lot of things to do. It's not just people with disabilities that have limited access. So therein lies the rub at times. Should waiver come in because the community lacks? Or how do we build the communities to support what waiver can enhance? So when we talk about local, that's where we're going to lean into, because we're DDARS now. That's where we're going to lean into AAAs and providers and innovation there and community leaders. And, you know, Teresa in VR, she's over to my left here. You probably can't see that in the camera. How do we do this differently? Because what we've been doing, I'm not saying it's bad, but it's not gotten us to where we want to. We've deinstitutionalized. That's a wonderful thing to celebrate. We are serving more people than we have historically. I've given you those numbers not that long ago, but there are a lot more folks out there with need. We know we've got a limited amount of what I call the public pie, if you will, right? So how do we do this where we can support the most individuals in need that we can? It's not, I got to prove, let me get everything I can, because there's other, how do we do that better? Yeah.
And just to add on to that, I think in most cases, the people who are picking up the slack that the community is not providing and that the waivers are not providing are the families.
Yes. And I hope we talk a lot about this as we move toward waiver reset. The noise is there and we need to address this. Families do have to, communities will have to support, right? We know that no matter what we do. So how do we support families? We have a model that was designed years ago, particularly around folks with intellectual and developmental disabilities, to fix the person. Guess what? The person doesn't need fixing. The environment needs to be supportive. The environment, the family, the community that's supporting them needs to be supported. How do we do that better? You know, Jim, I'm looking at you and I know you know this stuff because you and I have had these conversations for a long time. We have a service, behavior management, behavioral consultation, you know, whatever we want to refer to that. That's not about really fixing the person. It is to support them, but it's really working within that environment, because that needs to start early on, right? Because you're not, I'll just use me, you're not really gonna turn a screw or push a button and change a whole lot. I can modify some things about me, but you know what? I've learned some things about myself. That's kind of the goal of that, but people in my life have learned some things about me too. And they know how to better support me and interact with me. So that's a great point. It's something we miss. You know, in my former world, the most insightful conversations I had were with families, because tell me what is it that you are really seeking out of this service? Because we focus so much on service. I'm like, I don't want to hear about the service. What's this feeling for you? And then we can get there.
And I'm very encouraged about the level of care consideration, because right now there really isn't any level of care consideration. I mean, I have a very complex daughter that I am expected to care for until I'm 80 and my husband is 83. We bathe her, we dress her, we feed her, we manage meds. You know, I don't know. I look at my parents who are 81 and 82 right now. I can't imagine them doing what I do.
Right.
And we have to fail her before we get any help. There has to be an emergency because we can't do it and something bad has happened. And so I think that needs to be taken into consideration in these new waivers. And that's where I think level of care, like I'm attending that same meeting you are tonight.
Yeah.
And that's the thing. Like, I totally get, and someone said at our last meeting, you know, take what you need.
That's it.
And leave something for other people.
So that we can
I am
address
totally
those.
okay with like not having everything that I ever wanted. I can't even imagine that, honestly.
Right.
But the thought of doing what I do until my husband is 83 and I'm 80 is just, and I love my daughter and we have a nice life. I mean, I don't need more right now.
Yeah.
But I might need it before I'm 80.
Right.
Thank
And I'm afraid of like losing some of my benefits if, like if they think that I'm okay without the benefits that I have. But I'm like, I need the support that I need in order to be where I am today. Because where I am today, I'm fine. But down the road, if they decide to take it away, I'm like, no, I won't be okay without the support. That's what I'm afraid of.
Yeah, and I'll just circle back and then hope I will move on because this will be, really the remainder of the day. This is the discussion before us. And Kathy, I'm going to lean back in to a comment that you made. The advantage to us sharing with you with significant timeline of where we're headed is that you're at the table. We can hear these conversations. There's much more transparency. The disadvantage, the downside to that is we recognize that can cause anxiety, concern, because there is some ambiguity. You know that. I mean, I'll just
Right.
take it down. If you're planning a trip, there's a lot of unknowns, and this is a lot bigger than planning a trip. But it's just but you're along for the journey and you're part of the planning. So we're not intentionally being less than concrete. It is because we're telling you where we're going. And there's some things that we're definitively flagging, saying we've got to address this. And you're going to hear me speak to this. One of this is individuals that have more complex support needs. How do we do that better? How do we coordinate care better? The model that we're using now isn't working. It is not. We've got to do it differently. And so the plus is we're here. The option would be we would do all this behind a closed door in our little four walls upstairs here on the fourth floor. And 6 months before we're going to roll it out, we'd make an announcement. Here it is. And that can be done. That's not the path that we've chosen. So I do want to recognize, we understand it's going to cause questions. It's going to cause concerns. We want that though. We want that engagement. It's not an intentional, we're holding back. This is the planning phase. You're at the table and not just folks here. So
Kelly, I was going to say
Thank you.
too, I think we have to do a better job, Talia, I think this is a good point, of educating people. There's this fear, if I stop using it, I can't get it back, essentially. So I think what we see is folks, at least in my role previously, we would see a lot of just continuing to use a service. And it wasn't from a bad place, but it was this fear of, if I stop, what if I need it in 10 years? And people that's not, you can, right? But I think it's so they hold, and so then it's like they're holding on to it, not for coming from a bad place, but because of this not understanding that, or just not having the information that's, you might maybe later in 10 years, maybe this is a support you want to explore, and that's okay.
Right.
So I think sometimes, and that just you saying that made me think of that. I think some of that's been created. And I think we don't always address. That's why sometimes new services, people aren't always using them. It's because it's that they want to, but I think they're afraid that if I stop, I don't really think I need behavioral sports anymore, maybe, right? But if I don't, so I think we've got to do a better about education and what that means and doesn't mean.
Right.
that's that ebb and
Of your
flow.
life changes,
Right.
things change, right? You might, my life changes. There are more supports I need now than maybe I did 10 years ago. So I think, or in different areas of my life. So that's where that fear comes in, I think. Sometimes.
Right, because there's someone that was talking about, like, she was on the CI's waiver and then she got off, and now that she's having more health issues, she's trying to get back on, and it's kind of hard for her. And it's heartbreaking because, like, I'm having a lot of health issues too, but you know, because it's just normal for me. Not really normal, but it's scary.
Yeah, I think, and maybe that's one of the things, when you hear me talk about ebb and flow, I'm not necessarily talking about, oh, you're eligible for the waiver, today you're not, tomorrow you
Yeah,
will be.
you're-
What we're talking about is the utilization of that waiver and the services on it.
Okay.
So I'm gonna just use some numbers. Let's just say, you know, I come on today and I have a level of need and I'm using $25,000, just use simple.
Mhm.
But then, you know, things improve and, you know, I try to diminish and I'm down to
Kelly,
$10,000,
closer to the mic.
right? And I stay that way for years,
Mhm.
years, maybe a decade or whatever. And then something happens in my life or there's a change, a need, and now my utilization goes back up a bit. And perhaps it stays there for a while and maybe it ebbs back down. When we are looking at a sustainable system
Mhm.
and we are looking at capacity, and you all know we
Oh.
have so many waiver, we use the term slots, I hate it,
Yeah.
but we have so many waivers that we can budget for. And how we make that prediction is based on the average spend. So if
Oh.
everyone is maxing out everything they can all the time, what happens? The cost per slot is high, and therefore we're saying we can't add any more waiver slots.
Oh.
But within all the people getting waivers, if some are up and some are down and that changes, what should happen is that average cost comes down.
Okay.
Then guess what? Maybe instead of 10 slots now,
We
I
can
can
take-
have 15.
Mm-hmm.
So that's what we're talking about. Take what you need when you need it. Maybe you still have the slot. You may go through a period of time. Maybe I only need case management for a while. Things are going well. I just need some help coordinating. And that would change. But if we have a system, a model in place that allows for that, that impacts the spend, which impacts the availability of slots.
Right.
It isn't money is needed to fund it, but we're driving this first from that, you know, person-centered life course, what you need when you need it to augment what already exists in your life, whether that's
Right.
your own personal skills and strengths, family supports, community supports. But what we haven't seen historically is that it's typically I'm on and then I'm not letting go and I'm just going to keep adding. And I don't think anyone's doing it intentionally. No one's
No.
trying to cause harm. It's often fear led. If I
Right.
don't use it, I'm going to lose
Right.
it.
Because honestly, like I've had so many case managers right now. Like honestly, I had one and then I got a new one and then recently I got another new one. And it's like, why? Like I don't need a new case manager. I like the one I had. But my case manager I had before, he advocated for me to run my own meetings, same as Darlene over there. She wants me to advocate for myself and run my own meetings. But when I go into that meeting and my mom wants to run it, I'm like, no, this is my meeting.
Can I just add?
Can I piggyback on that just really
Oh, yeah,
quick?
please.
We're excited, I mean, as case management for the new role. I'm just worried about the capacity of it too. And the turnover with case management and everything is probably a direct effect of a lot of the changes
Yeah.
that have come
Mhm.
to. I just want to be cognizant of
You know,
that.
and again, this isn't nothing is a quick fix. It never is. It's, you know, there's a long curve
Mhm.
with any change. And we're really talking about cultural change. You know, you've heard us lean into whatever term you want to use, case management, system navigation, care coordination, service coordination. We all know what we're referring to. The goal is the role of that case manager isn't to broker a budget. and it isn't to check boxes on a piece of paper and say it got done.
I really hope that
So, you know, hopefully just kind of leaning into that more and being able to invest in it more. Here's the rub. We can't invest in it more until we get some of these other things in line. So that's where we've all got to start rowing in the same direction.
And
I
I
agree.
hope that that part of that too is, you know, the example you gave at the beginning about, you know, maybe first steps being the right support and school being the right support and VR and all those things. And then the second example you gave where someone was utilizing duplicative services. I hope that then the conversation becomes how can these state entities communicate better
Oh, yes.
together
Mhm.
and how they can communicate better to families and tapping into organizations being told that maybe waivers not right now, but school services should be doing it isn't enough. Tapping them into someplace like InSource is helpful to that.
Yeah.
Tapping them into places like Indiana Family to Family and the ARC so that they have this navigation, they have this assistance, because just being told that they don't have, like, this isn't the appropriate service at right now isn't enough, right?
Yes, I
Because,
agree.
you know, being
Mhm.
told go to first steps and then you have a 6-month wait list. Well, what do you do in the meantime? Being told go to the school, but the school's not equipped to take care of your child or provide the service you need. So what do you do in the meantime? And so I think that's the biggest gap, right? It's yes, the right services for the right people at the right time, but maybe the right service isn't available right now. And there still is a need and there still is a struggle. And we need to be tapping into those community organizations
Agreed. Mhm.
to make sure that families are still getting support.
Agreed.
Can I just ask, and it's kind of a question, maybe a comment and commentary for all of us. I do think this isn't, I think for those of us that are sitting around this table that have been here for a while, this isn't a new thing. What it
No.
is which I really appreciate, because it's a long, like you said, a long arc, a long evolution, and it's hard. I think we have historically been kind of trying to drive this into what it always has been versus
Yes.
rethinking about how we implement services to better embrace this idea. So
Yes.
I do feel really good about that. And I can appreciate all the uncertainty and the concern that creates. I think central to a lot of this is we've been using waivers as a replacement for building the communities, helping
Yes.
support communities, and maybe even expecting our communities to step up.
Yes.
And I think I would say, and I don't think it's a surprise to anyone here, I think most communities still lack that capacity.
Mhm.
And I think that's a concern probably we all have. And I think there's maybe two questions. One is, what's the state? And I'm not just talking about this agency or this division, but, you know, from policy to our state agencies to, you know, including Department of Education, like, how are they embracing this
Mhm.
and the role that they play to make sure that those holes don't. So there's that. And then how are they embracing this and encouraging these communities that, let's face it, we need folks and communities and employers and, you know,
Yes.
transportation system, every system out there. We need them to be inclusive of not just people with intellectual disabilities, but people of all different needs, including this population. I mean, it's not just this population. It's just
Indeed.
this population is the one that has some extra resources that we've been able to kind of fill these gaps in the community. So I say that because I don't think that's just the state's leadership expectation, but I think we're going through this process. And if at the end there is no grand vision beyond this room in this state to demand that the expectations in our communities change. Okay, so that's on the government side and what we can and should be expecting in that. I think on us as providers, as community members, as advocates, as the advocacy community, I would argue that we got to get out of our box
Yes.
and stop talking just to each other and expecting each other to solve these
Yes.
issues. We should be advocating in these spaces where transportation doesn't exist for anybody, that there or people are falling through the cracks that we care about, to get in these spaces and start fighting those fights. Because here's the thing is, these are rights that people have, and they're up to us and our community, people with disabilities, to damn well, you know, expect those rights and advocate for them. The government's not going to come and solve that. And I think we have, and that doesn't mean they shirk all leadership responsibility, but I do think that we as a broader community need to start looking at ourselves in the mirror of what we're doing in these communities rather than saying, well, you guys fix it, because it's not going to happen. And I don't think it's going to happen. I don't think the capacity is there financially to do it today. 10 years, we're going to be having the same conversations, just with far fewer people being able to access these services. Anyway, I'll stop there. I just think it's an important thing, though, as we plan, like how we need state leadership to really do that. Also, we need a lot of local. It's not just them, though. It has to be us. It's going to be. So,
Derek, I appreciate that. It's an example that I love. And I mentioned I'm from a rural community, and actually in my former role served several rural communities. But to your point, we were able to get support and implement a rural public transit system, not based on the fact, because I was coming at it, I'm working with individuals with intellectual development disabilities, but connected with another community organization that was focused on those that were, economically impacted, people that were turning from the criminal justice system, and we came together and we got our local officials to recognize this wasn't just an issue for folks with intellectual development disabilities or an issue for folks with physical disabilities. It was folks that had lost driver's license, folks that were whatever, and employers got on board. That's how it happened. It wasn't the IDD provider coming in and running a route, right? That's what was the game changer, but you had to get the community see that it was a community need. So yeah, and that's kind of what we're speaking to. There is a public policy state piece of this, and then to your point, we got to stop talking to one another, and we've got to get out there in the communities and how do we begin to build that.
I think that's part of the issues here is we're the payer of last resort, and we've been looked at as the last resort, not just the payer, the last resort. So if the school can't do it, we can do it. Or, any of the other kinds of programs that are out there.
Which is interesting because we do lean into it. Certain things are entitlement services.
Right.
But it has, and Derek, I think you acknowledged it, because there were resources. Waiver has been utilized perhaps in manners it is not intended, because there are resources there. So again, realistically, we know this isn't we're going to flip a switch and it is an evolution. This is iterative, but it won't change if we keep trying to fit it into this model that existed 5 decades ago, which really was built more around an institutional concept. And so it is kind of changing it up, if you will.
So there are some things that are pretty concrete. One of the things that has, I think, been an embarrassment for Indiana for a long time is this 80-year criterion for parents. And I think that if we're resetting the waivers, we should reset it based on the needs of the community, and 80 years doesn't meet anybody's needs. It's just, I know it's probably expensive to drop that to 65, but morally, I think that's something that we should consider.
They tried 72. Was that 2 years ago? It went to the legislature, and they just said they couldn't afford it.
But can I speak to that? I think
Right.
that's why, and I think it was back in November. That is why the reset, a new model, a new array. That's one of the pieces, because the system now was built on, we were only serving a small number of individuals that could qualify for what was it called? The DD waiver, the big waiver. So yeah, remember those days? I've been around too long.
Yeah.
So, and then those costs were, what happened again is costs were skyrocketing. What do we do? 20,000 people on a waiting list. What are we going to do? And so everyone came together, advocates, all stakeholders stayed, and it was, here's the answer. It's all good if everybody can, the family support waiver, everybody can get a little something, support individuals while they're at home. And then we have this, emergency need waiver, the CIH, the comprehensive waiver. And that's where we're at. And that's why those criteria are there, because of that model. In this reset, that concept disappears. So what we are talking about is no more algo either, but utilizing these assessment tools and a budget, once that functional eligibility is determined, a budget that's developed, based on support needs and having levels within. So would we still probably have some reserve capacity that recognized emergent situations? Because I don't know, the need continues to grow. Will there always be a waiting list? I can't answer that. But I think you do need some things in place where you can respect that. But this new array is moving away from this model, right? That forces that.
Oh, okay. So like I feel like maybe we should all come together as like a group and like go to the legislators and tell them what our needs are and what they need to be met. Cause a lot of people need the support still. And we gotta voice ourselves and tell them we need this, we need this. Please don't get rid of that. Please don't get rid of this. But maybe we can add it together or something,
I think, their charges, they're in charge of the budget for the state, and that's the whole, not just the
Right.
waiver. It's the Medicaid spend, it's the spend on education, it's the spend on transportation. So, they're looking at that as a whole. What they leave to us is the model to try to address those needs and to work with them, what we know,
Our constraints.
the constraints that we have fiscally. We know as we're planning forward, I'm going to be very honest with you, we know we are looking at maintaining Medicaid growth, the state appropriation at 2% year growth. That's the charge that we've been given. So, we are trying to work within that model, starting out that funding source, and then looking at needs and designing a model that allows us to provide the most necessary, efficient, effective support within that.
I like that.
Okay? All right.
Kelly, I'm gonna move you.
I know.
We kind of talked.
We have talked a lot. So, Holly designed these slides and she couldn't be with us today. So Kathy and I are going to tag team it. We have really talked a lot about this, which was the whole intent. So this was it was organic and it worked well. We do want to just kind of touch on waivers, and we've talked a lot about what you're going to see on this slide. Some of our current efforts around sustainability, our movement in case management, and then it's really a follow-up, if you will, further enhancement, talking about involving Derek and evolving communities, and then we'll kind of close out on the reset.
Went too fast.
It's okay. I talk fast, just not as fast as you. So we really have already spoken to this, and I thought Holly did a wonderful job in designing it. But one of the things that we have, talked about internally and what we've started to uncover in our communication is, I think sometimes there is a misunderstanding about what waivers are, what they aren't, what the intent is, what they're meant to be. So, just from a federal level and then, from a state, from the federal level, the purpose really is it has to be cost effective. You'll hear cost neutrality, and that references institutional cost, that it would cost no more to provide these services and support in a home and community setting than it would in an institutional setting. So that's straight from federal level, always has been. That's not a recent change. Cost neutrality. Now, the way that we measure that right now is on an aggregate, what's the average cost per person, institutional versus home and community based. But that is something that is monitored at a federal level as well as state level. So it has to be cost effective. It is called a waiver because home and community-based waivers are not an entitlement service. Medicaid state plan, Medicaid is an entitlement services. Medicaid waiver is not. So it is waiving, if you will, that right or that support in an institutional setting. And the support will be provided in a home and community-based environment. Again, not meant to bring the institution into the home or the community, but it is in lieu of. And, you know, sometimes we see this, let me lean into the assessment piece. I've seen some misunderstandings. I speak to people and they're like, but I need help with my medication administration. If we're speaking about health and wellness waiver that's under our purview, the level of care must mean this person requires nursing facility level of care. That means their needs rise to the level that they would qualify for Medicaid placement in a nursing facility. So that need then is not going to be met in a nursing facility. It will be provided in a home and community-based environment. It's not I have some needs to be able to stay in my home. I have nursing facility level of care needed. So it's the same thing with individuals with intellectual and developmental disabilities, that functional eligibilities, those areas of need and activities of daily living exist that would otherwise entitle the person to an institutional level of support, where that, you know, supervised group living, and so forth. Rather than receiving that support in an institutional setting, the support is provided in a home and community-based setting. Again, not to recreate, because the standards for an institutional setting also don't apply in the community, and we don't want them to, right? Institutional is very clinical, medical, right? There's more restrictive, and meant to be that way because it's saying that level of need exists. They also have to be appropriate. The waiver has to be able to meet the need. Perhaps the person desires the service, wants that waiver, but the waiver cannot effectively and appropriately meet the need. Not in a safe manner, not an effective manner. Not saying the need doesn't exist, but the home and community-based waiver at this time, maybe not forever, but at this time is not appropriate. So maybe that individual does need a more intense level of support or something that's offered somewhere else at this stage in their life. And I'm not talking about because of lack of availability of another support, saying that may be the more appropriate. So when we look at it, it has to be, it achieves the outcome and the goal. And then, you know, Melissa, you talked about this. Choice within the waivers is what is available, you know, what are the options within available resources and within the parameters of the waiver. It's not, you know, Kim, I think you said that, everything I want kind of thing. And, you know, several of you have referenced this, but this is not just a state thing. This is federal. Waiver cannot replace, cannot be in lieu of entitlement programs. We cannot be duplicative of Medicaid state plan services on waiver, right? If it's offered on state plan and available, it can't be duplicated. So it is not in lieu of entitlement programs. Department of Education, First Steps is an entitlement program. Medicaid is entitlement, not Medicaid waiver, but Medicaid. Or informal supports. We do need to look at what does a community typically do, a family typically do, what's available within reason. Next slide.
Good question on that. So just going back to the cost effectiveness so the cost neutrality aspect, I mean, a lot of states still have, obviously we've done a good job of getting rid of state operated IDD facilities. And so that's what the states will use from a comparison for institutional costs, apples to apples. What does the state of Indiana utilize for that cost from an institutional setting? And then also looking at it from the cost, from an aggregate cost, are you looking at budget or are you looking at cost utilization on spend?
So for the IDD waivers, what we utilize is the cost of the comprehensive rehabilitation medical needs facility.
For the CIH.
Yeah.
CRMF.
Yeah. So we refer to that as the CRMNF. For the nursing facility level of care waivers, that would be the cost of nursing facility.
So the CRMNF right now isn't it something like $7.25 a day or something like that?
Yep, you're about
Nice
spot
recall.
on. Nice recall. Somewhere right around that, yeah. So you can do the math.
For individuals that meet both, will there be some kind of way to figure that number out too?
What do you mean by
Both
that?
nursing facility
nursing
and
level of
ICF.
care and institution.
Do you mean to figure out the aggregate?
No, to figure out what the cost neutrality would be.
It is, the way that we do it now, it is based on, so this was your next question. So the way that we look at that is it's what we experience in the per member, per year, or per member, per month cost. So that's based on claims. So paid claims.
All
And
claims.
all paid claims. So just easy math, we spent $1,000, we served 10 people. $100 per person is the average cost. So that's how that's calculated. That's very simple. That's napkin math, but but that's how it's done. And then that's it's compared to either for nursing facility level of care waivers, it's compared to the cost of a nursing facility placement. And then for the CIH, it's compared to the CRMNF cost.
Even though there are.
Hey, Jim, you gotta
Yes, not currently, but we would, yes.
you
we're
gotta
still
use the
using-
microphone.
And you gotta use the microphone, apparently.
They're telling
So
me
what-
that
what
they
was
can't
your-
hear you
What
if
was your
you're not.
question, Jim?
I said, even though there aren't any female CRMNF beds right now.
Correct. And that is, just to clarify, that is all Medicaid claims, not just waiver claims. So if there are
Yes,
state
thank you.
plan costs and for those waiver participants, that is included in that overall cost neutrality calculation. And then for the family support waiver, it is looking at all of those other ICF levels combined. That is in terms of population of who we're supporting, it makes sense for us to delineate those in that way.
And that data, I think that average cost is presented in the QFR for the,
I think it was Steve.
Yeah. The background, yeah.
but what's presented there would be for that the FSW, because that's the other SGLs and not the CRMNF.
Yeah.
Cost. All right.
I just moved. Sorry. Go ahead.
Did you move me already? Okay. Again, we've talked a lot about this, so I don't want to hit every point, but I have had some questions, and I found it interesting as, again, someone that's a little long in the tooth that's been around a while, because I've had folks say, well, we're moving away from person-centered, people aren't able to choose what they want, get everything they want. I'm like, well, wait a minute, that was never the intent of being person-centered. Person-centered means that you do prioritize, that you focus on an individual's needs, obviously their values, their culture, their preferences in planning, to your point, and decision-making. It doesn't mean that waivers should or can provide all of the resources and, particularly a person's preferences or wants. That is not the intent of the waiver, the purpose of it. Being person-centered, though, is about respecting that individual's autonomy and then treating them as the driver of their life, right? As, who knows you better than you, right? I know me better than me. Sometimes I don't like that, but I do know me better than me. And I always lean into, for those of you who've been around, and I think NARC might have hosted Dr. Laura Bracken, several years ago. And I was always excited by her because the piece that we often forget when we talk about life course, or we talk about, I used to call it pathing decades ago, where we talk about being person-centered. That is about supporting an individual to make informed choices and decisions, but with that, person accepts responsibility and accountability, and there are consequences to choices and actions, and working within the confines of that. So just kind of talking about that, that, again, what we've been hashing out here and discussing is that person-centered is looking at the all, looking at the all. Next, Jessica. This actually came from a slide deck that I think Kim Opsahl and I presented almost 3 years ago. But it's one that I always lean into because, again, and I'll just speak for myself. Having done this for a long time, I think sometimes we lose sight of what home and community-based services are and what waiver is. This really is kind of just straight out of the CMS guidelines and technical guidance, but you'll see certain things highlighted, and I hope this came forth in that robust discussion that we were having earlier. But it is about providing access to meaningful and necessary services and supports. So you heard me say, and again, I'm not being critical, the goal isn't about let's just fill the day or fill the hour or make sure there's a staff person or there's activity going on. That is not the goal of waiver. It is to be purposeful, meaningful, and necessary. And that is to be done in an individual's home and in their community rather than in an institution. It is about being respectful of preferences, the goals of the individual, and the health and safety needs. It must be cost effective, as we've highlighted in our previous discussion. And these last three for me are key. What do we really want when we're supporting someone in directing their life and being person-centered? Home and community-based services, the waiver is to facilitate the participants' involvement in the community. Now, I'm going to tell you, there's always someone that goes, now, wait a minute. What if my mom is 80 years old? And I said, no one said we're forcing people to go out and be engaged. So we're all different. Some of us are more introverted. Some of us like to go out and engage socially in large groups. Some of us like to stay engaged with a small group of people. Whatever that is to that person, but community isn't a house or a town. Community is, right, your network. So maybe it's you want to stay connected to a high school friend that lives away. Maybe it's that, you know, your neighbor and you are very close and you want to, you know, just stay in touch and have contact. But maybe it is you like to go out to the local club on a Friday night. Whatever that is about being involved in your community and finding ways to help you access the community in a manner that works for you. Look, there are folks out there with and without disabilities that they don't even want to go to the grocery store and shop. They want it delivered, or they want it bagged up and they just drive up and pick it up. We're all different. Also, that next to the last bullet, and what we're often not seeing happen in our current model, the goal of home and community-based services is to facilitate and encourage the development of those typical relationships, those social relationships and the connections, not defining what that relationship is or the intensity of that relationship or with whom, but it shouldn't be my life is built on being with paid supports, and these are the only people that I interact with, and they're my own, you know, my only social interaction. Home and community-based services weren't meant to be the social aspect of the person's life. They were meant to support that involvement or the development of. We've got to do better there. We haven't done that well. And the other one is it should facilitate independent living. Again, that doesn't mean everyone is going to live without some level of support, whatever that is for that person. But there are folks, I've seen it, every one of us that have done this for a while, there are folks that eventually live completely independent with minimal supports, or maybe just built with support from what I would refer to as kind of typical support. that was nurtured in development through home and community-based services over a period of time. There are others who will always have some level of support, but we should always be looking at that. How do we do that better? And how do we allow people to be as independent as possible? You know, one of the things is if I have someone in my life 24/7, I want y'all to think about that. Do you want someone with you every hour of every day, every minute of every hour of every day? Sleeping, waking, bathing, toileting, eating, shopping. Okay, there's a level of support, but how do we do it in the least intrusive and the least restrictive way? Our answer has been, our current model is, we're a staffing agency, and that's how we do it. That doesn't guarantee quality. It doesn't guarantee outcomes. I'm not saying there isn't quality in some of those situations, so please, no one be offended. But it doesn't necessarily indicate that we're doing that well. And we also know our current model isn't sustainable. How many people need services? Let's take money out of the picture.
A lot.
All right. Is there a workforce available to have someone accompanied one-on-one every day, all day long for the rest of their life?
No,
Right.
probably not.
So we've got to do better.
Right.
Next slide.
I like being with my person a lot because she understands and supports me really well. So we have that connection, but I wish she was with me more because I love her.
You know, and you know, I speak to that sometime, and I think, you know, I was in the provider world for 30 some odd years. I did direct services, case management. I would hope for you, we can, you know, you can develop some relationships with folks that you feel that way about, that are beyond paid supports. And I will also say to you that there are individuals that I met through paid support that later on I no longer served, wasn't connected, nothing ethical, that I've maintained friendships with, and I support them in a typical and natural way.
Right.
Right?
Right.
But, you know, I will say, and again, I completely understand what you've put forth, and but our intent, we don't want, the direct service staff aren't family, they're not friends. We don't want paid friends. We want to help you develop those relationships.
Right.
So,
Can I just add something? Because I feel like I should here, that people in the family community, and I know that sometimes the family community needs to be educated to do things in a different way. But sometimes what you just described feels like a unicorn in a fantasy.
yeah.
And so creating a system that is going to have some expectation of unpaid help for people who aren't as delightful. And I mean, not that my daughter's not delightful. She's delightful, but she's hard.
Oh, yeah.
And there just are, as you all know, I'm not telling anybody, I'm just putting it out there in the record. I'm not assuming that you don't understand this. But sometimes I haven't had a lot of people that just volunteer to hang out with my daughter just because, or even just to support me. My mom is dead. Like she was literally the only person who did that for me. And so there just has to be a little reality.
No,
in
I
this,
acknowledge
you know?
that.
Right.
And I hope that's when you hear me say there are folks that you have to acknowledge there's some service and support need. And so I do acknowledge that. And I don't want you to think that.
I'm not saying that you don't. I'm just sort of putting it into the record.
I'm saying that for the all, because you've heard me say, I don't want folks to think that there's not a recognition that there are folks that have a higher level of need, and that the development of relationships is more difficult, and they're perhaps limited, right?
And in this day and age, they're just people that work, and life is hard. And I think we're more disconnected than we've ever been in this community thing.
Yes.
And I think, you know, as a person who looks around, I don't feel like the world is more friendly to people with disabilities right now.
No, they're not.
I think we're more aware, but I don't sense, you know, like I have a church that loves to think that they're coming alongside us. Bless them, you know. But that doesn't mean they really are. And I'm sitting here thinking, and for me, to get to where you're talking about is me taking on another job of training people how to help me. And sometimes I just don't have the capacity for that. I'm just gonna be honest with you.
And I agree.
Right.
And when I talk about the
Right.
home and community-based supports, that really is what we want, is when there's intervention, is working not just with the individual. How about working with some others about how to support you and build that? That is more challenging. Look, it's not easy.
Right.
I'm not gonna sit here
Well, and I
say
think
it
getting
is.
more
Right,
people
but-
to, like your example in your church, is to care. Like I that would bother me. Like that might not be my experience, but I would care if and would want to help advocate for the people within my, do you know what I'm saying? So it's like, how do you get those people to step up who, or, you know, or push or whatever, who aren't necessarily personally impacted by it,
Sure.
but to have some empathy and to care about it? Because like you said, it sometimes it's a battle and you got to fight it, and you got a lot going, you know, and it's how do you,
And in fairness to these people, and I think this is true, it has ebbed and flowed over the years.
Yeah.
And
Mhm.
little kids are great and easy to take care of and to help with. You know, 29-year-olds
say it's
are a
more-
whole different
yeah.
thing.
It's
Right.
more challenging, I think, you know, as we do move into adulthood. And I think that's just kind of a broader whole, Derek, you know, just referencing that.
It
Building
was,
communities, and I mean, just as a culture, perhaps in some ways, and you can look at, what I was always amazed at in my work is in some of the most rural areas
mhm.
is where I saw the best level of community support for people with more complex needs, because they
Right.
were more connected as a community. They knew one another and they came together to sustain their community. And I always wonder, like, how do we replicate that? I know, I mean, you're not going to do that in the
Right.
city of Indianapolis, but within whatever communities, because people would say it's tough in a rural community. I'll be honest with you, in my former role, it was easier for me in the rural communities because of those relationships, and I could network those.
And I also think that the more capable a family unit is,
Yes.
it's just sometimes you don't look like you need help.
Right. With me, I look like I don't need help, but I do. And I rely on support from my people, but I also get attached. So that's me. I'm always an attachable person. Like when I was younger, I was really attached to someone at a Girls Inc. And she left and I was devastated. But when I get attached to someone, I will be devastated when they leave. But that's just me. That's my way of expressing I don't want you to leave me.
Okay, I'm gonna let Kathy take over for a bit.
Okay. So I think one of the things we included in this slide deck, and again, recalling my previous sentiments about the right services for the right people at the right time, is essentially this this image in a nutshell, where we are really trying to help individuals fully realize all of the resources and connections that they have across all aspects of their life. And I will say, I think we've had several conversations with this group about a number of proposed changes that we're making with waivers, with services. I think those have been enlightening to us in a number of ways, some of which I will say, as somebody who I think I can say I drank the life course Kool-Aid a while ago, but I think if you have in fact done that, then you can look at possibly this image and some of the fundamental underpinnings that it conveys to say, we aren't really doing this today. I think we agree and believe and can support conceptually what this is presenting. I think, and I'm looking as us, as an agency, as a entity that has been promoting this philosophical framework. But I think in some of the conversations and what we've seen in some of our reviews at the individual level, on a case by case level, I can now very quickly point to and see where we're not practicing this across the board. And so I think also some of our efforts here are recognizing maybe where we haven't fully connected the dots for individuals and families, for case managers, for providers, on just what we mean when we say that we really should be doing a real inventory of somebody's resources, their personal strengths and assets. We seem to be still stuck in the eligibility specific space.
Absolutely.
And I think where that hurts in thinking and talking about some of the proposed changes and some of the things that folks have mentioned today is, in doing that, people are reliant on what is inherently a somewhat unstable system, because that system is ever changing. That system is very much driven by factors that we don't always have a lot of control over. I know during COVID, and I know no one wants to go back there.
No.
One of the things that we probably said more than the COVID phrase, or as much as the COVID word itself, was backup plans, and saying to folks, what is your backup plan if this system of supports fails you, or this aspect of your life doesn't pan out, or this shift doesn't get supported? What is the backup plan? And having that, so that for changes, even changes like we're talking about, teams are thinking through how might we don't have a community or community-based or technology support that could possibly serve as a backup for this person in the event that this plan changes or the circumstances here change. Those are not the sky is falling kind of conversations. I think those are really insightful conversations about what it is that could temporarily help and support someone. But I think we felt important to kind of highlight this because we are seeing in some of our service plan review connection, even during the public comment for the amendments, we saw where, like, this aspect, this conceptual kind of framework, we can find and see now where we haven't quite executed this in the way that it's fully intended. And I think when we know we have is when we can have these potential changes and people don't feel like the sky is falling, and they don't feel like, oh my gosh, I have no other recourse. I have nothing else I can do here, and this is going to be detrimental to my life. I think it points to, if all of your eggs are in that basket, if all of your eggs are in the eligibility specific support basket and it's the waiver, that's probably not a great way to set up your life. I don't think anybody is setting up their life in that fashion. So we'll probably be circling back on some of these elements just because we can see where it hasn't necessarily been executed to the extent that we've wanted it to be up to this point.
Right. And I feel like my safety and security is my support system with my staff and my house manager. But my mom doesn't see the point where I have a great connection with my house manager. She doesn't like that. So she just wants me to do something else. But I feel like my house manager supports me better than my mom in some ways, because my mom also has a lot of stuff going on too. And then she also takes care of my dad and my granny. So I want her to be able to back off and have my residential staff and my house manager be able to support me in the things that I need, but my mom just doesn't understand. So how would I go forth telling her they're my safety and security part? Like, I just don't know.
Well, I mean, my suggestion would be the same to you as it would to anyone else. If there is, someone in your life, if it's one of your support team members that you trust, I don't know what services and support you receive, and I'm not going to delve into that because that's private. But if there's someone that you could talk to that might help you have that conversation with mom, or, discuss how you might go about it, that would probably be helpful.
Yeah, I would, because my mom and I's relationship is tricky because, like, she really gets on my.
Well, yeah, I think that's normal.
Yeah, she's just. It's okay. I don't care. My mom is just my mom. She won't care. It's just she loves me. It's just we butt heads, and I don't like
That's just
that.
as a daughter and a mother, I get it.
Yeah, she's my legal guardian too, so that's just.
It might be good to take that back to Self Advocates of Indiana and work
Mhm.
with the team to identify ways to talk to parents. I know from a council perspective,
Mhm.
we try and help families with those same conversations, and it can be really sensitive.
It's hard.
It is so hard.
Because when my mom cuts me off, I get aggravated and snap and be snippy. And my staff are like, take a breath. Like, don't get so agitated.
And
But
from
it's
a parent perspective, it's also out of love.
right.
And it's not to be controlling, but I think it's also hard. I'm a parent of a child with
Mhm.
a disability,
Right.
and I'm a sibling, and it's really hard to kind of let go and let your family member be independent, even when they're showing us that they can and are independent.
Yeah.
It's so hard. So
It hurts me
Yeah.
because, like, I want to be independent, but it's like she's not letting me.
Yeah. All right, Melissa.
So kind of along the lines of what our fantastic family advocates were talking about, just looking at kind of the practical realities. And when we're talking about philosophically increasing or trying to build up those natural supports, I think it runs into a bit of a disconnect when, if it's like, okay, I want this person to, my neighbor has agreed to drive me to college, or my neighbor has agreed to take me to work, or something like that. But the ability to pay them, or then they have to become a waiver provider, and, so balancing those natural supports with that health and safety, wanting to make sure people are protected and not taken advantage of. So can you talk a little bit about what the future of that might look like?
I don't think the future of that isn't any different than it is now. And I think perhaps what I'm not talking about replacing waiver with now everything has to be done by a volunteer or typical. I think it's looking at what's practical. You do take health and safety into consideration. I think sometimes that's where the struggle is. What one person considers health and safety isn't what another person considers health and safety. I think, beyond philosophically, the practical point is, I think we, as this advisory council, we as a state, we as a society, there are decisions to make. Do you want to spend a larger amount of dollars on a small group of people, or is it try to, bring the spend per person down and support as many and build communities? I think that's where we're at, trying to balance it. So again, it's not meant to say our solution is replace waiver with volunteer and family, but it's leveraging waiver in the manner in which it was intended, which is to augment and not replace. And that does mean, you know, families and communities will, as they always have, continue to provide support for individuals. So. Are we ready to?
I think for me, just, I guess as a clarifying point, natural supports for me is a big spectrum of, you know, if I was, you know, taking my kid to go bowling once a month with this group of kids, and maybe he has exceptional needs, and eventually that group of kids wants him to be there. And so then they are like, no, we'll come get him and bring him. Like, I think that's to me, that's a natural support. That's not necessarily somebody saying, I'm going to volunteer my time to do this thing with your loved one. It is we want you to be included, and we're going to do these things without expectation of some kind of recompense or payment in order to make sure that those individuals stay involved, stay included in their community, in their friend group, in their network, in a way that happens to offer respite to the parent or the caregiver during that time period, in a way that we can't as a system probably replicate very well without, you know, some of those community aspects being supported locally.
Okay, moving on. Do you want to speak a little bit about some efforts that are underway currently as it relates to sustainability? I think most of you have likely tuned into some of the quarterly financial reviews. You've heard me reference it here during these council meetings and other public meetings. I know you've heard Secretary Rowe in many of his public presentations. We have been charged with containing not just waiver, the Medicaid spend, the Medicaid budget within the state of Indiana. And our means of doing this and the way that we have strategically approached this isn't to take just an arbitrary slash across the whole at this point. And by that, I mean DDARS has not said, we're just going to reduce all the rates by 3%, or we're going to eliminate this service entirely, or we're no longer going to do X. We are really leaning into person-centered, all of the principles that we've just laid out, the intent of waiver. So presently, we have asked our case managers to connect with an identified group of individuals. I think there are about 1,200 that are on the community integration and habilitation waiver. I think it was the top 10% on spend, right? And what we are looking at is their authorized budget. And I'm stressing that because that is different than looking at an algorithm. This is looking at the authorized budget. This is not the allocated budget that's associated with an algorithm. So an algorithm says I'll just use Kathy. I keep using Kathy. So Kathy has been found eligible. She's on the CIH and her algo level has been assessed at whatever 4. And that comes with a maximum budget allocation of whatever the dollar amount is. And I can't tell you that right off the top of my head. Now, that's not the approved budget. That's just saying, based on the assessment, that up to this amount could be authorized if the need is identified, exists, and all these other things, right? Entitlement isn't available, blah, and all the other resources. So what we are looking at is their authorized budget. The planning has been done. There's a service plan in place. And for the people that do this, You'll often hear notice of action. It's the approved annual budget, the authorized budget. So the top 10% of those. So those are being looked at on a individualized basis. So again, there has been no charge to reduce every budget by X amount. Now, I will say to you, and I have said this quite simply, I'm always leery to say it because I think people are going to take it literally that I'm doing this or we're doing this. We serve a little over 9,000 folks on the CIH. I think it's close to 9,200, but I think claims each month are a little over 9,000, if my memory serves me well. And we know what we have to save in Medicaid spend, and I know that particularly in waiver. So I've targeted about 5% savings, and that's what we're looking at as a whole. 7% would be like the ideal state. We could simply say everyone that's on the CIH, their budget is going to be reduced by $7,000, and we have magically saved $63 million in federal and state money. We'd be where we want to be.
Mhm.
Now, $7,000 per year per person, that's really not a lot of money, but not everyone can do without that $7,000. That's why we're looking at this uniquely. And I'm not saying this exists, but there may be somebody that has $40,000 worth of service that perhaps is no longer necessary.
Right.
And someone else, maybe the budget is, the approved budget is spot on. So the goal is to bring the team together to discuss the person's need, talk about all the resources and supports, and really even talking about, are we at a point, have we just relied on this because we historically have? Are we being restrictive? The other thing that we're really looking at is we do, over time, we have a lot of individuals that are being supported in independent individual settings, meaning they are getting 24 hours of support one-on-one in a household. That should be the exception, a rare exception, and not the rule.
Out of the 1,200, how many is it?
I can't tell you that off the top of my head. Now, I'm not saying there aren't folks that are going to live alone by themselves and be supported through waiver, because there are a lot of folks that live independently and maybe they're only getting 8 hours a day or 6 hours or 12, or they're using some remote supports, or they're working and doing other things. So please don't mistake what I say, that people can't choose to live by themselves. They can. What we are talking about is if your preference is to live alone, but you have a level of need that you need one-on-one or supervision, it may not be practical that waiver can pay for that if a need doesn't exist, to say if there's some need at this present time. We have somehow gotten there where we once were. So we are going to be leaning into shared staffing. I say shared staffing, not shared living. Shared staffing doesn't mean you have to live in the same household. There are some folks that, I would say, let's be creative. Maybe you live in a duplex next to someone. Maybe you live across the street. Maybe you're in the same apartment complex because you just need someone close by. Maybe you need someone within 20 minutes and there's a phone. Or maybe you can use technology and remote supports and virtual. Exploring all of those. I'm going to jump ahead a little bit, and then when we get to this slide, hopefully we can skip it, because my piece, we were going to talk about how this works. This was an experience, and I'm not going to use a name, but there was an individual that when I was in direct service and providing, came to us at the time, homeless, having some mental health conditions, extraordinarily complex. Kim, to your point, one of those folks, not a lot of individuals wanted to be around and, in support. Really wasn't a lot of natural supports. Came to be known to me because of the shelter and some other folks in the community that wanted to do good. This was a long, a couple-year journey for this individual. We went from some temporary stays, for mental health support needs, working with that provider, to one-on-one 24/7. And I know this person today but even prior to my departure, we had diminished to 8 hours per day. It's now less than that, and building connections. That happened over time. That individual needed to live alone during that had to live alone. It wouldn't have been healthy for him or anyone else in the setting. But working toward that goal, that's what we're talking about. Maybe at this point in time, it is an extensive level. What we've seen happen is we start with the extensive level, and that doesn't always diminish, and we don't look then for other alternatives. And there are a lot of reasons for that.
Right.
Sometimes, I'm just going to be real, it's like, well, we've solved the problem, staffing's there, it's all good. And we're not really concerned about, is that person now benefiting from the least restrictive setting, and what about the quality of their life and moving forward? No one's intentionally trying to cause harm.
Right. I also.
So that's what we're doing. So there's been a lot of, and I'm sorry, but
You're
that's
fine.
what we're doing now. There's been a lot of kind of miscommunication, maybe misunderstanding. There's no arbitrary, everybody must be cut by X. I have tried to quantify it and say, I say I just because I've been charged with this, but we have targeted a number to bring down our Medicaid spend to, Kim, I think it was your point. Someone made the point, maybe it's Derek. On the state end, we're looking at the entire spend in Medicaid, not just waiver. We haven't done an effective job on our end of coordinating that. That is one of the goals of Reset too, to better coordinate that care. We should see improved healthcare outcomes for folks if they're getting waiver supports and appropriate care coordination. So right now it's a one-on-one for those identified groups, but we want to replicate that across all our waivers. That should always be the process in service planning.
Right.
So that we don't get to this point where now we're conducting these targeted reviews, right?
So for me, I used to be 24-hour, like all the time, but I gradually got off 24-hour. I live on my own. I almost own my own condo. I have an amazing boyfriend, amazing staff and team. But where I see myself still needing the support. So like I have remote support during nighttime.
Yeah.
And then I have my staff during the day or afternoon, evening. So I still have that, but I still see as myself gradually working towards without having staff.
And that's
But-
the goal. Thank you for
Right.
sharing that.
But I feel like I still will need staff because I don't drive. So maybe I just keep staff and keep the remote support. I feel like I do great with that. So thank you.
So I want to I think this is a little twofold because what Kelly's talking about in these budget reviews is necessary, but it is also from a federal compliance standpoint, we can see in some of these scenarios where we are not as teams preventing the provision of unnecessary or inappropriate services and supports, and that is a regulatory requirement in the settings rule that we have to adhere to. So some of these cases, and I maybe mentioned it earlier, of is there the assessed need for somebody's current service level is not reflective of what their current situation is. It is a reflection of a historical concern for that person, for example, of something that happened to them 15 years ago. And so we've never really kind of said it's a just in case assessed need. It's not a real need. It's a what if that might happen again? So we are asking teams to go back to say, is that happening? Because if that's what the assessed need is, that actually doesn't fit the definition of what a functional assessed need is. That is a preference, and that is just that is a fear-based decision about what the service actually is. Now, if at some point that individual does have a risk that appears that does need to be addressed, then the team needs to be dynamic and respond to that. I think in some of these, what I would say, the percentage of folks that you identified, that seems to be the spot where we're seeing more of the individual need, not necessarily driving. And when we say an assessed need, we're not talking about somebody finds an assessment and conducts an assessment. What we're saying is, what information are you documenting in that service plan that says this is what this person needs? Is it historical incident reporting information? Is it, reports from the physician? Is it like what collateral or additional documentation points to the need for this individual? It can't just be my mom wants this for me, so we have to have that. My mom said I might not do well here, so we have to do this. That's not a functional assessed need for you. That is somebody saying, that's someone's opinion about you alone.
Right.
So those are some things that I think we're wanting to make sure that from a sustainability standpoint, yes, we have done our due diligence here, but we also don't want to run afoul of our fiduciary and administration responsibilities from a federal requirement standpoint. And that's the other element there is a fiscal associated with that, by the way, and it's losing our federal match. And that's a much bigger fiscal conversation that we are not interested in entertaining.
I think we can move to the next slide. So I referenced that these approved budget reviews are distinct from an algo review. So I just wanted to touch on that. We are also, and Heather, I'm looking at you, it's like, shake your head at me if I say you're in the weeds more than I am. So we are also reviewing the algos that have been assessed for individuals that are, currently supported on the waiver. Historically, again, what has happened over time is there's always been a process to reassess and request review, if you will, of the algo level. But what has happened and what has become embedded is the only time that occurs is when there is deemed a need for an increased level of support. Never, hey, we think things may have changed, need to reassess. Likely it's a lower algo. It was interesting, again, just because I've been around a while, I just, looked into a few as just kind of a case study of people I knew, and I'm like, wow, that algo's way off. I know that person, they're no longer at that level of need. So again, we're not doing this to be punitive. It really right now is to assess the accuracy of our current system, if it's working well. And if we do find allocations, algos that are way off, moving to adjust those accordingly. Again, there would be a discussion around this support team, coming together, talking about supporting the person's needs. So it's not done behind, closed door, and the individual and team aren't aware of that.
Kelly,
Yes.
Are the algos just on the CIH waiver?
Yes.
Okay.
Yes.
Right now, that will change.
Yes, and there will be. It won't be the current process. It won't be the algorithm, but the goal is that the new model of waivers, there would be a support needs budget based on that assessment.
I do realize that the algo is basically going away. But I do think that one thing that any planning body for any change needs to be careful of is when we tell people, which I believe was even discussed at the top of this meeting, was that just because you don't use services doesn't mean you're going to lose them. And so you shouldn't feel like, oh, I don't. But at the same time, if you're going to review algo scores based on your needs, that's going to be based on, well, this person isn't really taking advantage of some of this, maybe we ought to redo an algo score. And I think that that could be a dangerous thing where you end up where
Yeah, I
you're
don't,
telling people,
yeah,
one thing and
utilization
then-
of services doesn't identify need.
well, I understand that, but in terms of the person, like if I were to look at 20 people who I know really well, and I were to say, oh, well, that person probably shouldn't be an Algo 5. Why is that? Well, 5 years ago, they had these problems, but they're not really experiencing that anymore. And subsequently, their services that they're utilizing have gone down. And so I think that when we tell people, don't worry about if your services aren't being utilized, that's never going to have an outcome, when in fact, it probably will if we're going to be looking at Algo scores.
Well,
And maybe I'm just-
possibly, I mean, I'm not going to say that couldn't, but here I will say to you, I'm pretty direct on this again, and not just in my role here at the state, because I've witnessed this over time. When the algo was first introduced, it was very common to see algo scores of 0, 1, 2, 3. Those have, Heather, those have predominantly disappeared. And what has happened is we've identified, we know what level of need is necessary to get a particular budget. And so 4, 5, and 6 now have become the common domain. So I think that's part of it too, the current system. So I'm being honest, and this is on a, that's at a state level, when we're looking at some of the things that we need to improve, that's one of those. That's not unusual over time with any tool, as it becomes known. But yeah.
Kelly, I've heard you say that before, and I just want to be clear, because I bet there are other people like me that don't really know what you mean. So what I hear is that there were people 2 decades ago, I'm assuming, who would come on as an Algo 0, which to me, I hear that's a really high functioning person who got on the CIH waiver. And you're saying that now that same person, this is what I think I'm hearing, that same person will be labeled a 4?
Not necessarily the same person, but as people have come on new.
So are there less people that are level
No,
0 that
what
even
we're
get
talking-
considered for the CIH? I mean, that's what I would hope that means.
Yeah. Well, I can't say that because there are a lot of categories for CIH that aren't necessarily based on complexity, right? So there are all varying levels of individuals that are joining the CIH, right? Death of a primary caregiver, to your point, caregiver over 80. There's DCS age out, SGL transitions, people moving out of supervised group living, out of group homes. So what I am referencing is, and this is not unusual, it's not unique to this tool, but the algo is ascertained by assessment, interview, a process, questionnaire, collateral. Over time, people begin to understand what that is and what triggers certain algo levels. And so then they know the budgets that are associated with that, and that just happens. And there's again, I'm not saying anyone's doing anything purposely unethical, that just happens. So that is one of the things that we have noted. And the other thing is the process hasn't afforded itself to, hey, the level of need has changed legitimately, perhaps 5 years ago because of things that were, maybe there was an event, maybe a life stage, trauma, what have you, or a skill set that needed to be developed that has since been developed that isn't going to go away, right? Not a temporary. We just haven't historically seen that reassessed or reevaluated, and it doesn't come down. What we do see is, hey, things have changed, this person's needs are up, we need to reassess. So the trend has been, it goes up, not down. And again, nothing intentional, nothing untoward, but it's systemically, we've identified that hasn't been occurring.
I think part of that though too is a lot of people who are coming onto the CIH waiver are usually going through some kind of transition, and it is going to, necessitate more staffing possibly, and the needs are more, yeah. So,
I would
I
not
know.
agree with that. I would not agree with that.
Really?
Not with the, not
Not-
with some of the
not as a
reserve
whole.
capacity on the CIH that is not inherently indicative of an emergent issue or need for that person. We have individuals coming into the CIH out of group homes all the time who do not have a particularly excessive or exceptional need.
No, I would agree with like the group homes and
And
stuff, but
that's
I'm like talking
that's a
like
good
if the
chunk of
parent
who's
dies
coming
or
onto the
something like
CIH. That's-
that.
That's the majority, Laura, of who's
Okay.
coming onto the CIH.
Your point is it's not static either.
Correct.
It is
Those
not,
needs-
correct.
You're right, those needs could be high, but
Yes.
will they?
Right, they're
are they
high
expected to
now,
be
and-
Yeah.
forever?
Yeah.
Yes.
As-
And they
as-
don't ever change is the
Well,
point.
What,
They-
what,
even if they do
Change
come
it
on
up.
high, they don't ever
Right.
try and take down.
one of the problems too is that the ICAP is not a particularly great instrument.
You
I-
are correct.
I mean, it was designed as a one-on-one assessment, and it's done over the phone, which that right away shows that it's poorly administered. But more importantly, it's normed for a population that's not disabled, and so a lot of people, when they get this phone interview, they might say, "Oh, well, you know, this particular person does really well with math." Well, not when compared, you know,
Yeah.
you're making a false comparison. And so a lot of those initial algo scores were ridiculously low. And that's why there was a lot of reevaluation. And that's a big part of that elevation. It's not just grade inflation over time. A lot of it is because the initial assessments were done incorrectly because of the ICAP. Just wanted to point that out.
I think that's all I had on that. So this was the slide that I was referencing. So I already shared, my one story. I know Holly had some examples, which I don't have those examples. But I think we've all talked about this. I mean, you've shared your personal journey, and thank you for that. Thank you for, transparency. You certainly didn't have to do that.
You're welcome.
I shared my experience in supporting individual. I'm looking at people sitting at this table that I know have done that very thing. Ann, I'm looking at you. I know I've worked, just since my time in the state. So it really is, I think, when things work the way that we intend them to, and Kim, even to your point, I think on some of these, yeah, we've got a long road. It isn't going to happen overnight. But this really is about involving our communities and supporting our communities to evolve. As I said, we have a system that was built on a time when individuals that were different, that had disabilities that were different, weren't at home and weren't in our communities. They were in institutions. And we still have communities that aren't as accepting as they should be, nor supportive of individuals that are different or unique or have a disability. And I think one of the things that I know Kathy and I are passionate about is I know I get a lot of calls sometimes. We've got an individual and they have an intellectual and developmental disability. Where's the place for them? That's the call I get from a community member or someone
Concerned
outside
citizen.
of our system that's a call I don't want to get. Where's the place? Is there a place I can, sometimes I've had people say, send them, drop them, take them. That is what we fought against, and that's what we've tried to move away with the institutionalization. You've heard Secretary Rhodes speak to that as something of which he's most proud and should be, and Indiana should be. The thing is, we need to take the next step. We got to take the next step.
I do have a question. Actually, it's more of a comment. We've talked about the person-centeredness, we've talked about the budget, but we also probably need to be cognizant of the fact that our rules and regulations are set up for facilities.
Yes.
And that providers really get this risk versus benefit fear, right? Because of regulatory compliance and also because of lack of caps on liability. Providers are really struggling to afford insurance these days for a variety of reasons. But I do think as we move forward, we need to add that into the module that we're looking at to say, if in fact we move away from this regulatory facility-based compliance, what is that language? What does that look like, right? Because I think in a perfect world, we've got this unicorn, but if your providers can't buy into it because of X, Y, and Z, we're gonna put a hurdle there for everybody.
I agree.
So I just
Yeah.
wanted to bring that up. Thank you.
I think that's a strong point. I think, Derek, you were talking about, this, but a lot of it is, it's not just looking at policy, it is looking at rules. A lot of those, and some of that's at a federal level, and some of that is at a state level. But again, a lot of the rules are designed around an institutional model of care. And so it is going to take evolution in that arena as well. Do you want to take the next slide?
Yeah, so I
Case
know, we've had a lot of conversations about case management, waiver case management in particular, and again, purposeful conversations in that space, really looking at this idea of access and inclusion, which we've talked about a number of examples in this conversation about what do we mean by access and inclusion and what does that look like. And that's where, when we talk about case management as advocates, that's what we're talking about. It's case management and acting as advocates for the people that we support in this access and inclusion space, ensuring that there are avenues, resources, and information for individuals so that they can make informed choices to ensure they have that access and inclusion. And then looking again at all resources, we talked about that integrated STAR slide, the life course, how we need to get really centered around that. Identifying gaps in support. This is to say, you already have this assumes you already have some things working for you in your life today that you don't need our help with. We just need to make sure we don't disrupt those things so that those things continue to work for you. Looking at entitlement services, particularly, I would say, as it relates to youth, and making sure that we're looking at all of the available options for individuals and where should some of those resources come from, and whether or not it should be coming from the waiver or it is better met through those other options, and what needs then are addressable by the home and community-based waiver system. As we talked about, how we've created basically the funding model for waiver services, what goes into that math, how we identify how many slots we have available, what may be impending or impeding a state from our state in particular of having more slots available. And it is some of these cost considerations that Kelly talked about and things that we're trying to do to not only infuse some sustainability measures in, but also identify places and spaces where if we can find and make available more slots for people, then we feel confident in being able to do that. So that's case management is a huge piece here. I will say we did the case management RFP was released this morning. For those of you who haven't seen it, I'm sure Laura's gotten her email maybe. But that will kick off another, I guess, strategy on our part to help streamline case management service delivery. Anytime we issue a request for proposal, again, this is a request to interested entities who may want to contract with the state to provide waiver case management services. And this is our effort to align case management approach across all of the waivers that DDARS administers. And so there will be some changes, particularly as it relates to our integration of the aging space and the health and wellness and TBI waivers. So that solicitation is posted. For those of you who don't know the procurement process, we offer an opportunity for folks to take a look at that information and then submit us questions in writing so that they can get answers to things that we thought we were super clear about, but maybe we were not. And so that question period will probably kick off here soon. Folks will have until December 12th to submit their written questions. I say that because that's also my birthday, in case anybody's interested.
I do know that.
Yes, do not.
calendar.
I'll be reviewing written questions on my birthday. And so the intent is to have this solicitation and procurement go live in July of 2026. I was just looking to make sure. So you can go out and review that information. It's publicly posted on the Department of Administration website. But that's about all we can say. That's really about all we can say about it. Given that it's a live procurement, we can't really answer questions about it, which is why the Q&A opportunity is there for interested entities. So we wanted to, just acknowledge that is out there in case you happen to see it. But also, as we've been talking about this potential for a while. So just kind of wrapping up, or I guess buttoning up that topic for our next steps going forward. And we'll hopefully have a great procurement.
And special thanks to Heather Dane and the Beads team for putting all the wheels under it to get that prepped. It was a lot of work. So.
Is there a number of agencies stipulated? I know that we currently have 6 in the CIH FSW space.
I think we put forth in there like a range.
Okay.
A number range. Heather's nodding.
Yep.
So yes.
I think there's a min and a max.
You have to read it.
Yeah, read it. I can't read
They're
it.
in the silent period.
That's fine.
Yeah.
Okay.
Does that mean you can't answer questions about like timeline of when it's expected that decisions will be made before the implementation of July 1st?
So I can tell you what the timeline says
Yeah,
on the
it's
website.
posted.
Like if you want me to tell you what the timeline is.
If that's there, I'll go look it up.
Okay.
So I think the last slide is next for the beads, which is a closure on waiver reset. And we've actually just been talking about this throughout the day. But I do want to note, and it's been referenced here today, what we refer to as our reset engagement has launched, if you will. And you'll see some notations on the screen in front of you. So 24 different meetings have been coordinated with a variety of partners. And so there's been some pretty robust, I think, conversation with those. And there are 2 more scheduled. And then there have been a kind of a different array. Was it 15? Okay. 15 conversations, if you will, with other partners, say advocacy organizations, providers, case managers, our centers for independent living. The numbers have been good. About 400 people have attended those already. And is that right? 13 more are scheduled. I looked at it and didn't realize that.
That's great.
And then we are also doing some key informant interviews. Our work is being supported not just by our team, but we use the consultant HSRI, or Human Services Research Institute. They are very well known to us. They know Indiana well. They are experts, if you will, across the nation. and home and community-based waiver services. So we've got a great deal of support in this process. And I just so you know, we do our part too. We're very pleased that we were able to support this work with a capacity building grant from CMS through Money Follows the Person. So we are using federal funds and salvaging our state dollars. So we're being frugal and conservative where we can as well. So we're well supporting this work. It is aggressive in that we are trying to engage with as many individuals as possible. This timeline is a little more compressed, honestly, than we had hoped. Because we'd like to engage with our stakeholders. But we are beating the bushes and hitting the road and doing this, I think, extraordinarily well. So more to come. There will be more and more concrete information provided, to this council as we move more toward waiver reset, kind of ferreting this out. What I ask of you today that are here at this table and all of you that engage with us or receive support and contribute to the system is, as I said earlier, we really are asking to think beyond the current system. We're not trying to mash what we want to do into the current model. So particular areas have been identified. We know, and Jim, I'm going to look at you on this because you and I've had so many conversations. We need to do a better job of supporting individuals with complex behavioral health needs. We need to do better at coordinating care for individuals with complex healthcare medical needs. Those are distinct. That's why I don't like to broadly say complex, because those are different avenues of support and care coordination, but it's all about care coordination. On the back end, we are already looking at aligning our data and review, like with Office of Medicaid Policy and Planning and DDARS and DMHA. We're doing more collaborative work, really looking at how do we better work together. We have folks that are supported in some way, shape, or form by all of those divisions, systems, funding sources, may have multiple case managers, coordinators in their lives, and here's what we're seeing. We're not really doing a great job of collaborating, communicating across the whole. So we may spend a lot of time, energy, and money and not being as effective with it in achieving the outcomes we desire. So it's not just about how do we save money within DDARS. It's how do we improve the effective utilization of the resources that are out there? Because frankly, how do we do it better? So as we're leaning toward reset, know that there are always that conversation on the back end as well. And that's all I've got to say about that.
Couple questions. So I know there's been, obviously, as you noted, a lot of really good conversations with HSRI and Aligned and all those. Is there a thought that what is collected in those conversations is going to be somehow organized and disseminated about what they're hearing and what individuals from all those areas?
We will share that.
Yeah, and I will add, because it sounds like I'm glad to hear several of you are aware of the one scheduled for today. And this is typical for us to use HSRI in this way. Part of it is you've seen here the number of activities or events that have been coordinated. We would not have the capacity on our own to make that happen. And we are trying to cast a really broad net with this effort. The other thing that it affords in this space is that by and large, state staff are not at those events. And so it provides an opportunity to speak freely and not sort of think there's somebody from the state who's, jotting my name down or, we don't do that. So, but we wouldn't anyway. But just to sort of, for those of you who are attending, recognize that's part of the reasoning and rationale why we would use them in that way is, to really, because we don't have the capacity, but it also provides a different layer of honesty, I guess, that you could feel free to engage in.
Jessica, we're going to turn it back to you.
Okay. I'll be pretty quick here too. Yeah, I'm gonna get the mic before I get yelled at. No, I was kidding. Okay, so just a couple updates on the training registry. As you guys know, hopefully, everyone needs to be trained by January 1st. I'll show some numbers here. We've got thousands of folks who have already completed the training, which is amazing. Just a reminder for folks that you might be trained twice. So we have a lot of people who were trained on their provider's original general protocols, who are going to also go through this training. The med administration is almost done. So hang tight a little bit. We're just advising providers and individuals just to train on the current processes. And it will be out within the next couple weeks.
Well, I need to take this training.
Not if you're not a home and community support professional.
Okay, good. I'm just an individual.
I just included this again, just that if you have questions, this is also a link. I'll put this in the notes to the registry. We're going to create an actual page on the website. Right now it's within the Beach page, which is fine, but there's going to be an actual button and like a main page for this. So I just wanted to share these again. And here are the numbers. So this is, I think we ran this, I don't remember, Kelly, a couple days ago, maybe. I should have put the date as of, but so I don't know why that shouldn't be showing there. Hold on, let me move this because I don't know why this is showing. You can't see all the numbers, but so total 22,000, total time spent 97,000 hours, and most active day of it's Wednesday, which is kind of an interesting thing. So yeah, that's a lot. And
do you have, I think the average time spent per learner for the certificate is about 7.5
was it? I don't know. I might have missed. Was that what it was? Okay. I might have missed that one. I would have added that on there. Okay.
So well within the parameters that we had, predicted to complete all the modules and achieve the certification.
And we're keeping track of providers that we believe should be registered as an administrator based on what we're showing as what services they provide. It's not really too many, which is good. So we'll be doing some outreach to those specific providers to make sure that they're seeing our notifications about this, and so that they can register as an administrator. So
and we're pretty close. We had predicted, I think, again, for those of you that are listening, I think the council's aware. We've never really had any idea how many direct support professionals are out there. So keep in mind, this is distinct to, this was based off some legislation. And so currently, this is a requirement only for direct service workers, often referred to as direct support professionals, who provide services, paid services through the community integration or family support waiver. So we've never had any idea of how many direct care workers we have in the system. It's just never been aggregated, collected. So I think we guessed, because Jessica and
I think we're the one who had it more accurate than me.
25,000 to 30. So we're at 22,000, nearly 22,300 certificates. So that's not all yet.
That's certificates. Yeah.
And they have achieved the certification. So I have a feeling we're gonna be over that a bit.
Some of them have left the field too.
Yeah.
Mm-hmm.
Yeah.
But it's because this has really been, I think really the uptick started in August.
Yeah, it started.
So August, September, October, 3 months.
And when I send out an email,
So
that
system
tends
capacity's
to,
there.
when they see the email, a lot of times that tends to,
But we are reaching out. We've identified providers who are not in the system, need to be. We're doing outreach. Cyra's doing outreach. We're comparing it, to our list, and then our team's doing some comparatives of what as well. So just again, spread the word. Not every provider is connected to an association. This is a requirement as of January 1, and any direct support professional that's being paid under those two waivers for those direct support services must be credentialed. Otherwise, the service is not compensable or reimbursable through Medicaid. And so
that was my question.
the provider If the provider pays someone to deliver a service who's not certified, that's going to be money out of their pocket because that's not reimbursable by Medicaid. Post January 1.
I
we
feel
are
pretty
mon-
good. I mean,
we're
monitoring the
monitoring
providers,
the
like I feel
system.
pretty good about the number of, we also have added it to the new provider. I've worked with Heather's team and Beats to add it to the new provider, you know, when someone asks about being a new provider, right?
Are you able to show, if you click on that, the registry, like, will it show on the screen? I
let me
don't know how this
see.
technology works. I thought people might, if they've not seen it.
I don't think
might
so,
be
but I can
interested to
try.
see
Hold
what
on,
it
yeah.
looks like.
We have a
Maybe,
second.
perhaps not.
I know, hold on.
I may goof you up.
Yeah,
The
you're,
link is to the.
you're putting me on the spot, Kelly.
to the
No.
registry.
Hold on, I can share it. I can share it.
Yeah.
Yeah.
I was thinking.
I just thought for folks that, no, not the platform
Okay.
itself, just
Yeah,
the
yeah.
registry.
Oh, yeah, that, yeah.
Just to show how it works.
So like, should I use an example? Oh, I know. So, I mean, I've done it. I can use an example. Do you want me to use the one you've given me?
Sure.
So this is why you're all staring at me. So I can't do this.
So you can go to the site and put in the first name and the last name of the person that you believe is, going to provide services. And then it will tell you, if they are indeed certified. You can view the certificate.
And we worked on this because it was taking too long. So they fixed it.
So it's searchable. You can also search just what services an individual provides. You could get, I think, a listing. There's different ways to search. This is available to the public. This is something that, ARC and NR work together on, but I know from a family advocacy perspective, this was something that's been sought for a long time to be able to verify that an individual has been appropriately trained. Again, I'm going to be totally transparent. While 460 IAC has laid out for a long time the requirements for direct service training that must be completed prior to engagement, that has been left up to each provider to design and implement that training and document it and be available. And what we have seen is there has been inconsistency across the state. And at times, perhaps there have been providers who have not adhered to that or had a training module. This at least provides a level set on that basic foundational training. And I will continue to stress this, and I did prior to my role with the state. The most significant piece of training and supporting an individual in these home community-based waivers, also required as part of 460 IAC, is what we refer to as the individual specific training. So providers are still required, any direct care worker providing support to a member through Medicaid waiver must know that individual, make sure that appropriate training is not just their needs, but their wants and their culture and how to support them, but their specific medical needs, behavioral health needs, their goals and their outcomes. That's most critical, but these are foundational trainings that are now consistent across the state. So this is a first for Indiana and in our IDD waivers, except for perhaps way back in some joint standard days. But
Thank you.
it's pretty exciting, and the system seems to be supporting the demand and the capacity needs.
So as a family member who goes to look for someone, I guess I'm trying to think of a scenario how this is helpful to families, because if a DSP hasn't gone through the training and they're required to go through that training to be reimbursed, what are the odds, I guess, now that I would go look for my DSP and not find them there because the company is not going to get paid?
It could happen. The way that this will be caught is through an audit.
Okay.
So if a provider would be unaware, or if a provider would choose, there is currently not, that mechanism. A desired future state but this is an investment, you know, in operating system, would be that we are able to, at the state level, track who the direct service provider is. Right now, it's billed by the provider entity. The provider has the details. So.
Gotcha. Thank you. That makes sense.
Is that accurate? Okay. I was like, was that clear, Jim? So in other words, if Kelly Mitchell is a DSP and I'm providing res hab to Kathy again, and I work for Acme Inc. Acme Inc.'s going to bill the hours to the state. The state doesn't know Kelly Mitchell provided that unless we go in and audit, which we do, but it's just not routinely claimed and reported that way.
So I guess this would be another tool. And as a family, like if you
So
have
this is a
concerns and you
tool,
could
if
look
you
and they're
have
not there,
concerns-
you could go back to, I could go back
Yes.
to my case manager and say, I have a concern because they should be certified and they're not.
Yes.
And then they can
yes.
escalate
And
that.
that's what launched really, I think, this initiative is there were families that reach out to legislators that said, we know this person X worked over here, these things happened, and now they're here. How can we have more insight? Now, the next iteration of this is to take it that provider of direct service remains in good standing. Now, that's going to require the development of a reportable complaint system and review. Those individuals would be flagged, so it's not just they're trained, they are no longer noted as in good standing and cannot provide, similar to CNA and nurse aid registry. But that's the next iteration of this, and that will be just a little, bit more down the road because there's some processes. But Jessica's leading our.
More complicated.
Yes, it's a little more complicated than this.
Anything for the good of the group? Parking lot, and I don't know that we
Good.
got. I think we got to me. What'd you say?
I said, I'm good.
Oh, okay.
I think we kind of went through.
Yeah, we
questions
did.
all the
We
way
got-
through that,
Yeah, we did. We did an amazing.
Okay, so just a couple things. Next meeting, January 21st, 2026. Conference room A. Teresa will be giving a BRS update. And then here is the rest of the schedule. I'll send you guys this. It is being posted, if it hasn't already, on our website, on the public rep website. You have all the calendar invites, but this obviously will be sent to the public as well. But if you need to reference that, everything is in person except for that last one. I couldn't get a room even when I did this a year in advance. So that's sometimes what happens. So this one will be virtual only in November, but everything else will be in person. So
Awesome.
yeah, so I will make sure I'll send this to you guys, and then I'll also, again, it'll be posted on the public.
So no
website.
question on the data that was submitted to the
I didn't receive any
council?
yes, thank you. I didn't receive any questions for any of the data. If for some reason you end up having one, just let us know. And as always, this will be recorded and posted on the YouTube channel. And that's it for 2025.